Very good afternoon to everybody assembled. Thanks and gratitude to Dhiman sir, who's my mentor, to Amit Goel sir, to my friend Dr. Surinder and Ajay for this fantastic conference, and I wish the Department of Hepatology, SGPGI, a great future ahead. With that, I delve into the next 15 minutes on AKI in HRS, AKI, HRS, and ACLF management strategies. So we had a lot of debate yesterday about name changes in MAPLD and NAPLD. Thankfully, there are some definitions in hepatology which are possibly less controversial and good to use up. So the fundamental thing, since residents are here, for definition, you need to first define the AKI, stratify the AKI, and then decide, does that AKI qualify into hepatorenal syndrome or not? But when you bring into the picture a patient with acute and chronic liver failure, then things tend to change. And then over the next 15 minutes, we would try to put into that where does hepatorenal syndrome and the other phenotypes fit into in the spectrum of AKI in ACLF. We'll try to answer it in 6 questions. Is AKI in ACLF different? Are trajectories important? Can we predict AKI in ACLF? How to differentiate between the phenotypes, evolving data on terlipressin, and what happens when you don't respond to terlipressin. So the overall prevalence, estimated prevalence for AKI in ACLF, this is across etiologies and across studies, is estimated to be between 41% within a wide range of heterogeneity among the studies. So to answer the first question, that is AKI in ACLF different from stable decompensated cirrhosis, which is very easily elucidated in these studies, which comes out that when you have AKI without ACLF, you tend to present in the earlier stages, you tend to be more hypovolemic. Whereas when you move into the phenotypes with ACLF, you try to present again in higher grades of AKI, as well as your incidence of ATN starts to increase. So that's the basic phenotypic differences that we have in patients with ACLF and without ACLF. So this is again replicated in the PARCEL cohort from the Rocky Ma'am study, which again shows as you go on in patients with ACLF, you tend to have a higher grades of renal failure, as well as a higher preponderance of ATN. So if the phenotypes are different, what makes the pathophysiology? This is the old school thought about the pathophysiology of AKI of HRS, which comes from defective EABV, activation of vasoconstrictors, renal arterial vasoconstriction. But then you put into ACLF, and this is what it turns out to be. So this is what it turns out to be. You've got inflammation plus minus infection that causes direct organ damage. You've got rapid deterioration of cardiovascular functions leading to ATN. You've got bile cast nephropathy. You've got development of abdominal compartment syndrome. And all these account for a multifactorial etiologies for pathogenetic processes that give rise to AKI in ACLF. So that answers the first question, that AKI in ACLF is different from that in standard decompensated cirrhosis. Our trajectory is important. What we have realized now that patients, that subgroup of patients who are in stage 1B, which was the subclassification between the stage 1, these are patients we need to identify early, because these patients sort of behave like patients with stage 2. If you don't identify them early, their progression to a higher stage of AKI, need for renal replacement therapy, rates of AKI resolution, and AKI in hospital survival are all lower. So what you need to do is to catch these people early and carefully pay attention to them. Otherwise, you land up in this state, which is the sickest cohort of AKI in ACLF, the ones with AKI stage 3 and with AKI stage 3 and ACLF. This is again Dr. Raki's paper, where they have taken patients who at presentation had AKI 3 or developed in hospital AKI 3. Around close to the tune of 60% of all the patients ended up requiring renal support. The resolution rates are dismal, response to terlipressin is dismal, and the mortality exponentially increases once you reach the stage. So can we predict, since we have already been discussing that the development of AKI in ACLF is itself a big challenge. So can we have biomarkers or predictors for that, which was again beautifully elucidated in this study with the PYRO model, that if you have got a predisposition of background, some degree of kidney disease, high bilirubins above 12, high ureas, exposure to nephrotoxic drugs, SIRS, and most importantly, circulatory failure, you tend to develop in-hospital AKI. Remember, these are the patients who come without AKI and then go on to develop AKI in hospital. Do we have biomarkers? Cystatin C in 2 studies has been shown to have
some ability to predict patients who can go on to develop AKI in hospital. And there is a recent AIM study which looked at proteomics parameter. They did a discovery phase, identified 54 proteins, landed up with metallothioneins, and found that those patients who have got a higher baseline values tend to have developed AKI during their course of hospital stay. So these are the evolving roles of how that sick patient who still doesn't have AKI can develop AKI within the hospital stay. That takes us to the third point. Can we differentiate between the phenotypes that are there? ACLF AKI, basically, if you want to bring it down to, is a functional AKI and structural AKI. So the functional AKI part would be those that would be hypovolemic, those would be HRS, and then there will be structural AKI where your fluid management becomes important because they may not be responsive all the time. And this differentiation is important. So does urine analysis, the most fundamental test that needs to be done, and if the art is sort of being forgotten more and more, if you differentiate in patents between decompensated cirrhosis and ACLF, what we see in this paper is that the prevalence of bile cast nephropathy is 79% in the ACLF group, and this is what it looks like. Other parameters relatively remain the same. And if you extrapolate this, and if you take this up to patients who have ACLF and AKI stage 3, you get three different variants. One who have cholemic nephropathy due to bile casts and high bilirubin levels, one who have ATN, and then you have got another group which has got cholemic plus ATN. If you see, the bilirubin crystals are very high in the cholemic nephropathy group, and the presence, as you have the associated presence of ATN, your presence of granular cast increases. So again, do you have biomarker data to tell you what type of AKI it is? This is Dr. Napoleon's study, where they evaluated NGAL, IL-18, and urine albumin, and they saw at day 1, day 3, and day 7 in patients with ACLF who had AKI versus those who with ACLF without AKI tended to be higher. Again, we have an ILBS data that was presented that urinary NGAL levels of greater than 1100 and renin levels of greater than 9.4 has a predictive capacity of close to 100% for detecting patients with ATN. So, but a different data has come out from AIMS. This is unpublished paper available on the preprint gateway, in which they have applied a different algorithm. They've taken patients with ACLF, patients with non-liver AKI, and then healthy controls, and looked for FABP1, IL-18, NGAL, and cystatin C. What they found out here is only cystatin C is helpful in differentiating between ACLF and AKI versus no AKI, as well as ACLF AKI versus non-liver AKI. But the problem is the study was not addressing a question of how do you differentiate individual phenotypes of AKI in ACLF. So evolving data of terlipressin. Terlipressin has been the go-to drug in standard HRS treatment. So this was the ILBS trial of comparing terlipressin with noradrenaline in patients with AKI stage 2 plus exclusion of other causes. They had included patients with sepsis-related AKI, which is often a confusion that what is going to happen with these patients who have sepsis-related AKI. If you see the reversal rates, they were all better with terlipressin in comparison to noradrenaline. But what's important to notice, see the overall response rate. The 14-day reversal rate is just 40%. So there is going to be a huge group that's not going to respond. And if you take that group which had sepsis-related AKI, they have lower response rates versus the non-sepsis group, but have comparable survival. So the question that has always been that since ACLF is such a dynamic process and AKI's presence and development is so rapid, can we tweak the natural algorithm of HRS treatment? The natural algorithm which says you wait for 48 hours, give albumin, and then see for addition of terlipressin, which was addressed in this year's ASLD abstract from Professor Serena out there, which was perhaps one of the most talked about papers in the entire conference, where they tweaked the rationale by giving terlipressin at 12 hours versus the standard dose at 48 hours and found better reversal, better survival, with the other group getting only more albumin. So there's some data coming out of SGPGI from Dr. Gaurav Pandey about patients with ACLF and canonic AKI, where they've used a protocol of slow infusion of albumin with furosemide and terlipressin, which they call the SAFIT protocol, and have demonstrated better ascites mobilization, 28-day survival, lower hospital-acquired infections, lower cytokine profiles, and lower RRIs. This was at ACG Abstracts. I think the paper is under consideration for publication. But when we use terlipressin in ACLF grade 3, there have always been concerns about safety. This is Florence Wong's paper, where they said that if you using terlipressin in the higher grades of ACLF, your rates of severe adverse events are higher. We have Dr. Anand's data from India, where the rates are not that higher, but he did not get to see that amounts of cardiorespiratory failures, though the overall numbers were around 20%. But what's important is that those group of patients who developed an adverse reaction to terlipressin, the mortality rates were upwards of 54%. And the predictors of adverse drug reactions were sepsis and baseline bilirubin. So what happens when you've used your terlipressin and you still don't respond? So this is what your predictors of non-response to terlipressin in ACLF is. At baseline, how severe your ACLF grade is and what your baseline creatinine is. And the dynamic change of that, you do a day 3 prediction. And if you have got ACLF grade 3 plus no delta change in creatinine at day 3, you're expecting a 10% response. So do we have biomarkers? This was again ILBS data presented last year at ASLD, where they used urinary NGAL and cystatin C to develop models whether they can predict patients with terlipressin non-response. And what they found was that a urinary NGAL, 2 separate models, one with an NGAL value of greater than 907, plus the ARC score as per severity, other with cystatin C of greater than 2.5, plus the ARC score as severity, both are useful in predicting terlipressin response, non-response. If you don't respond, what are your options? You have plasma exchange, which ma'am is going to talk to you about in the next talk. You've got filtration techniques, you've got CRRT on SLED. I'll be just taking a little bit of information on the dialysis things that are there. So what are data with what happens to these patients who end on to get CRRT or any mode of dialysis? Your ICU non-survivors are 71%, and 29% of them survive. Out of them, at least if they are still receiving renal replacement at discharge of 52%, only 8% of them undergo renal recovery. If you're not receiving RRT at discharge, you're going to recover about 80%. But these are very small numbers. And what this study also shows that if you have got a CLIFFC ACLF score of more than 59.5 at 48 hours of initiation of RRT, your mortality predictive capacity is around 0.8, irrespective of whether you have got access to transplant or not. So what is the evidence from nephrology ties? This is 2020's landmark trial of early CRRT, early RRT versus late RRT, where you don't wait for the development of the key indications like hyperkalemia, acidosis, volume overload, respiratory failure, and persistent AKI for 72 hours. The issue is the trial was negative, but this is the only trial which included a substantial number of patients with liver disease. So this was again has been seen in ILBS, which they have tried to see patients who are dialysis responders versus dialysis not responders. And what is just like the previous talk, we are talking about the timing to antibiotics. What this shows is that 1 hour delay in initiation of renal recovery leads to a 7% chance of decrease in renal recovery from the onset of vasopressor initiation. So this is what perhaps the evolving paradigm of AKI HRS management is. You've got 2 phenotypes, ones who can develop AKI, so keep a close watch on them. Urine output is extremely important. Creatinines may lag back. Use the PIO concept, look at the patient as whole, biomarkers for prediction. If you have AKI, identify the differences. How do you identify the phenotypes? You look at the clinical scenario in the whole picture, baseline severity, both of renal dysfunction as well as overall disease. Look at the urinary biomarkers, focus point of care ultrasound, both for looking at the fluid status as well as a renal flow indices. Certain things we are not still sure about is which would be if somebody comes with associated septic shock, what should be our resuscitated fluid, what should be the rates, what should be a target map, because in ACLF patients, sometimes if you keep on increase the vasopressors, they end up doing more harm. And how early to use RRT. So what's better to look at these patients is instead of labeling them as HRS, ATN, you look for an HRS physiology. If there is a feel that there is a HRS physiology that's going on, which may be overlapping with the other phenotypes, treat with terlipressin, possibly with the current trial early terlipressin. If there is non-response, see the predictors of non-response, then go on to your second line modalities of PLEX, filters, or CRRT either as a bridge to LT, but always remember that there is an eye to futility and when to call it a day for such a patient. AKI in ACLF is not a black and white umbrella. It's got various shades, and the management for those various shades and steps, each step matters because it takes us to our entire goal of having a better patient-directed management. Thank you, everybody.